Hey guys, this is going to be our first video on alterations of digestive function. So just a couple of things we want to keep in mind when we're thinking about the digestive system and potential for pathologies associated with the digestive system is we want to keep in mind, right, what the digestive system does, what's its function. All right, so has several functions, right? We have to digest nutrients. We have to have the ability to absorb them. And then waste removal. So when we're digesting things, really the high level goal is we want to take something from big to small. You're taking a nutrient from something fairly large in size and you're breaking it down to something small to the point that it will be able to be absorbed. And when we absorb things, remember, you're passing from the lumen of the digestive tract into the bloodstream. So the goal here is you want to get the nutrients into the blood. And then, of course, waste removal. We have semi-solid waste or feces that's going to contain things like water, some bacteria, but also anything that was non-digestible that we were unable to break down and absorb. Okay, so these are the major functions that we need to accomplish when we're talking about the digestive system. In order to achieve digestion, we have to think about doing it kind of two ways, right? You have mechanical, so anything to do with movement, and then chemical. Mechanical digestion includes anything to do with GI motility. And then chemical digestion, of course, includes our enzymes. And you're going to have different enzymes that are able to break down different types of nutrients. So for example, you'll have a suite of enzymes that can break down carbohydrates and another group of enzymes that can break down fat or protein, right? So this adds kind of another layer now because you have to make sure that you're producing the correct enzymes in order to break down the food that you've ingested. Okay. Couple other things about your digestive system that are important, and especially when we're talking about changes, right? So the second thing we want to keep in mind, or two things actually, is the concept of peristalsis and what a sphincter is. Sorry, let me correct my spelling here. Okay, so first peristalsis. Peristalsis, when we discuss digestion, is the way that the smooth muscle layer of your digestive tract contracts and relaxes almost in a wave-like fashion that will allow things to be moved or be propelled from one space to the next. Okay, we want peristalsis to be continuous and we want it to be consistent, meaning you don't want it fast on some days and slow on others. You want it to be like this nice, steady, continuous process. Awake, asleep, we're able to have proper GI motility. Sphincters. Okay, sphincter is a ring of muscle tissue that will open and close and allow things to pass from one space to the next. You have sphincters all over the place, but in the digestive system, one of the things that sphincters can do or help us do is achieve some separation and compartmentalization of the digestive tract. So, for example, between your esophagus and your stomach, you would have a sphincter, and then another sphincter between the stomach and the small intestine. This allows us some control and it allows these environments to be separated to some degree. All right, so speaking of sphincters, let's start with GERD. All right, so GERD isn't an acronym. It stands for gastroesophageal reflux disease. What happens when someone has GERD is you have the reflux of acid and pepsin, which is an enzyme to break down protein, or in some cases bile salts, from the stomach back into the esophagus. So, on the street, we say, okay, acid reflux. What does that mean? So remember, your esophagus is gonna connect to your stomach, right? Right here, we have to have a sphincter so that when it's open, things can pass through from the esophagus into the stomach. But when it's closed shut, which is the ideal, there's no regurgitation of acid from the stomach back into the esophagus, okay? So when someone has GERD, for whatever reason, this sphincter perhaps is either relaxed, which can be a side effect of certain medications, or it could be that there's deterioration associated with age of the musculature of the sphincter. So, and sometimes it's pressure forcing it open as well, which is how we could link it back to obesity. All right, so your stomach is okay with this very acidic environment. It's adapted to it and has special features that allow it to function, right, with in a very low pH environment. But the things around it, your esophagus, small intestine, don't have those adaptations, and so therefore really can't deal with that low pH environment. So, how do you know you have GERD?
GERD's the word.
You'll have pain, heartburn. Now, if someone has an acute episode of heartburn, they went out, ate a pile of buffalo wings, and then the next a couple hours later they have heartburn. Okay, that's acute. If someone has chronic heartburn and it is persistent, that's when we kind of flip the switch and say, okay, now you have GERD, and you don't just have run-of-the-mill heartburn. You take a couple times, it doesn't come back for weeks or months. All right, so we're going to have heartburn. You're going to have regurgitation of acid into the esophagus. That's going to cause a wearing, inflammation in the esophagus, which is called esophagitis. Okay, some people have difficulty swallowing. They have dysphagia. Some people will report out that it feels like they have a lump in their throat, for example. Okay, so the treatment for GERD, and again, you can have GERD for a variety of reasons. It can be something related to age. Some people have GERD associated with hiatal hernia, or there are some drugs that when you take them, they relax that esophageal sphincter, and so you have regurgitation of acid into the esophagus. An example would be benzodiazepines, which are used to treat certain mood disorders. Okay, so how do we treat GERD? So there's a couple of options. Obviously, when someone lays down at night, obviously acid, then just gravitational pull is going to pull back some of that acid into the esophagus. It's going to make it very uncomfortable and difficult to sleep, of course. So, all right, so to treat it, all right, so you can take antacids. What antacids do is simply neutralize the acid, bring it closer to a neutral pH so you don't experience that burning sensation associated with heartburn, okay? If it's connected to obesity, you would certainly recommend weight reduction, right? If you have a lot of weight around the abdomen, right, that's going to put some undue pressure back onto the stomach, which can force some acid up into the esophagus. For some people, they'll elevate their head when sleeping to alleviate some of the pain associated with acid regurgitation. But many individuals take drugs called PPIs. A PPI is a proton pump inhibitor. So what that does globally is it will reduce acid. So it's going to reduce the production of acid at the level of the stomach. Okay, so PPIs would include drugs like Prilosec. These take a little bit longer to work, but the effect is a little bit more long-lasting than something like Zyrtec, which is a different type of, Zantac, which is a different type of acid-controlling drug, and we'll cover those in a bit. Okay. Obviously, what you want to avoid is if you have this continual regurgitation into the esophagus, it could wear away at the mucosal lining of esophagus. You might get some ulcerations associated with GERD that's kind of not being treated. Okay, EOE. EOE stands for eosinophilic esophagitis. So this is inflammation of the esophagus, but what it's characterized by is the infiltration to the site of inflammation of eosinophils, which we remember from our previous videos is a type of white blood cell. And what can happen with this profound inflammation and the gathering of the eosinophils to the site of inflammation is you can get a narrowing of the esophagus, which can make it very difficult to eat and difficult to swallow, of course. Some of the symptoms associated with EOE would be dysphagia, sometimes repeated vomiting. So individuals might vomit several times a day, and if you're continually vomiting and having difficulty swallowing, obviously you're not going to really want to eat. So a person might experience anorexia, which really means the lack of desire to eat. So that's going to lead to weight loss. And if this is happening in a child, obviously they're not getting the nutrients that they need, and certain vitamins that are required, minerals are required for them to grow and to thrive. EOE is linked to food allergies and asthma, which kind of makes sense, right? Asthma, as we've already discussed, is an inflammatory issue. So that someone would have a secondary inflammatory issue. Same with eczema, right? Eczema and asthma oftentimes go together. So it's not unheard of that, someone would have a secondary inflammatory issue aside from the asthma. Okay, so how do we treat EOE? All right, they're kind of, how do we visualize it? So they can do an endoscopy with a biopsy, okay, to take a sample to see the presence the presence of eosinophils. So that's how we can diagnose it, plus obviously symptoms associated with the disorder. Treatment. All right, so to treat it, we have a couple of options. You can do an elimination diet, which, if you're an individual who's had some experience with food allergies, is often done to identify what their allergic or inflammatory trigger is. So you kind of take all the foods away and add one by one, add some foods back into the diet to see which of them is a trigger. Obviously, there are certain foods that are very often triggers in food allergies: dairy, soy, eggs, etc. So those are the ones that you'd maybe want to assess to see if those were your particular triggers, right? To see if that's triggering the inflammation. And then we can do a steroid treatment. So they can treat with steroids that are anti-inflammatory in nature. Some of them can be taken orally, almost like a rinse. And what that means, this will do is it will reduce inflammation. And the goal there is not only to reduce the inflammation, but that should hopefully open the lumen of the esophagus a little bit, so it'll make it easier for an individual to eat, to swallow, etc. Okay. All right, so the last thing we're going to talk about with movement is a hiatal hernia. So I'm going to talk about hiatal hernia and connect it back to GERD as well. Because the symptoms are often very similar. Okay, when someone has a herniation, it's essentially they have a tear in muscle. Okay, so remember, your esophagus has got to come down to eventually connect with your stomach. But to do that, it's got to pass through the diaphragm. And because of that, this opening is called, where this kind of space or gap in the diaphragm where the esophagus passes through is called the hiatus. So that's why it's called a hiatal hernia. What can happen in a hiatal hernia is the superior portion of the stomach can kind of bulge out sometimes, just at the juncture where the esophagus is penetrating the diaphragm. And so that's called a hiatal hernia. When someone has a hiatal hernia, they have similar symptoms, very similar to GERD. So they have things like heartburn and dysphagia, sometimes epigastric pain, which means pain in the epigastric region of the abdomen, and regurgitation. So the treatment for this, they can actually do visual confirmation that you have a hiatal hernia. Would be different though, because even though some of the outcomes are similar to GERD, it's obviously for a different reason. So on the front end, the patient would want to eat smaller, tinier meals, maybe a little bit more frequently, avoid the recumbent position at any time after eating, and control weight if it's an issue. But we may have to repair the herniation, repair the issue with surgery, which obviously for GERD, there's no surgical intervention that would make a lot of sense there. Okay, we're going to stop there. In our next video, we will kick off with the pylorus.